Hello everyone, and welcome to another chapter of Advanced Pharmacology. Today, under Unit 18, Therapy of Infectious and Parasitic Diseases, we will discuss Chapter 76, Miscellaneous Antibacterial Drugs. So, jumping right on in. Fluoroquinolones. The fluoroquinolones are fluorinated analogs of nalidixic acid, a narrow-spectrum quinolone antibiotic used only for UTIs. However, unlike nalidixic acid, the fluoroquinolones are broad-spectrum agents that have multiple applications. Benefits derive from disrupting DNA replication as well as cell division. Fluoroquinolones do not disrupt the synthesis of proteins or the cell wall. All of the systemic fluoroquinolones can be administered orally. So as a result, these drugs are attractive alternatives for people who might otherwise require IV antibacterial therapy. Although side effects are generally mild, all fluoroquinolones can cause tendinitis and tendon rupture, usually of the Achilles tendon. Fortunately, the risk is considered low. Bacterial resistance develops slowly but has become common in Neisseria gonorrhea, and hence these drugs are no longer recommended for this infection. 5-fluoroquinolones are currently available for systemic therapy. Fluoroquinolones used solely for topical treatment of the eyes will be discussed in Chapter 84. Ciprofloxacin, also known as Cipro, was among the first fluoroquinolones available and will serve as the prototype for the group. The drug is active against a broad spectrum of bacterial pathogens and may be administered by the oral PO or intravenous IV route. Oral ciprofloxacin has been used as an alternative to parenteral antibiotics for treatment of several serious infections. Because it can be administered by mouth, patients receiving ciprofloxacin can be treated at home rather than having to go to the hospital for IV antibacterial therapy. So, how does it work? Its mechanism of action. Ciprofloxacin inhibits two bacterial enzymes, DNA gyrase and topoisomerase 4. Both are needed for DNA replication and cell division. DNA gyrase converts closed circular DNA into a supercoiled configuration. In the absence of supercoiling, DNA replication cannot take place. Topoisomerase 4 helps separate daughter DNA strands during cell division. Because the mammalian equivalent of DNA gyrase and topoisomerase 4 are relatively insensitive to fluoroquinolones, cells of the host are spared. Ciprofloxacin is rapidly considered bactericidal. So where does it stand then in the antimicrobial spectrum? Well, ciprofloxacin is active against a broad spectrum of bacteria, including most aerobic gram-negative bacteria and some gram-positive bacteria. Most urinary tract pathogens, including E. coli and Klebsiella species, are sensitive. The drug is also highly active against most bacteria that cause enteritis. Other sensitive organisms include Bacillus anthracis, Pseudomonas aeruginosa, Haemophilus influenza, meningococci, and many streptococci. Activity against anaerobes is fairly to poor. So Clostridium difficile, however, is resistant. Which brings us to the bacterial resistance. Resistance to fluoroquinolones has developed during treatment of infections caused by Staphylococcus aureus, Serratia marcescens, C. jejuni, P. aeruginosa, and N. gonorrhea. Two mechanisms appear responsible: alterations in DNA gyrase and topoisomerase 4, and increased drug export. Bacteria do not directly inactivate fluoroquinolones, and there have been no reports of resistance through transfer of R factors. Its pharmacokinetics. Ciprofloxacin may be given again orally or via the IV route. After an oral dose, the drug is absorbed rapidly but incompletely. High concentrations are achieved in urine, stool, bile, saliva, bone, and prostate tissue. Drug levels in the cerebrospinal fluid remain low. Ciprofloxacin has a half-life of about 4 hours, and elimination by the hepatic metabolism and renal excretion. Its therapeutic use, therefore, ciprofloxacin is approved for a wide variety of infections. Among these are infections of the respiratory tract, urinary tract, gastrointestinal tract, bones, joints, skin, and soft tissue. Also, ciprofloxacin is a preferred drug for preventing anthrax in people who have inhaled anthrax spores. Because ciprofloxacin is active against a variety of pathogens and can be given orally, the drug represents an alternative to parenteral treatment for many serious infections, owing to high rates of resistance. Ciprofloxacin is a poor choice for staphylococcal infections. The drug is not useful against infections caused by anaerobes. Because of concerns about tendon injury, systemic ciprofloxacin is generally avoided in children younger than 18. Nonetheless, the drug does have 2 approved pediatric uses: the treatment of a complicated UTI and kidney infections which are caused by E. coli, and post-exposure treatment of inhaled anthrax. Its adverse effects, therefore. Ciprofloxacin can induce a variety of mild adverse effects, which include GI reactions, your classic nausea, vomiting, diarrhea, and abdominal pain, as well as some central nervous system effects: dizziness, headaches, restlessness, confusion. Candida infections of the pharynx and vagina may develop during treatment. Very rarely, seizures have occurred. In older adults, ciprofloxacin poses a significant risk for confusion, somnolence, psychosis, and visual disturbances. So here's a good spot to hit pause so that you can take a look at the patient-centered care across the lifespan on antibacterial drugs. And I'll start reading off the black box warning on fluoroquinolones as well as tendon rupture. So, rarely, ciprofloxacin and other fluoroquinolones have caused tendon rupture, again, usually of the Achilles tendon. The incidence is as high as 1 in 10,000 or less. People at highest risk are those 60 years and older, those taking glucocorticoids, and those who have undergone heart, lung, or a kidney transplant. Fluoroquinolones damage tendons by disrupting the extracellular matrix of cartilage in immature animals. A similar mechanism may underlie tendon rupture in humans. Because tendon injury is reversible if diagnosed early, fluoroquinolones should be discontinued as the first sign of tendon pain, swelling, or inflammation begins to occur. In addition, patients should refrain from exercise until the tendinitis has been ruled out. Although there are no controlled studies on the use of ciprofloxacin during pregnancy or lactation, limited data indicate that such use poses little or no risk for tendon damage to either the fetus nor the nursing infant. Because of the relative lack of data, however, alternative drugs still should be given whenever possible. Ciprofloxacin and other fluoroquinolones pose a risk for phototoxicity, or severe sunburns, characterized by the burning, erythema, exudation, vesicles, blistering, and edema. These can occur after exposure to direct sunlight, indirect sunlight, as well as sun lamps, even if sunscreen has already been applied. Patients should be warned about this phototoxicity and be advised to avoid sunlight and sun lamps. People who must go outside should wear protective clothing and apply sunscreen. Ciprofloxacin should be withdrawn at the first sign of phototoxic reactions. Ciprofloxacin, as well as other fluoroquinolones, increase the risk for developing C. difficile, a potentially severe infection of the bowel. Clostridium difficile results from killing off intestinal bacteria that normally keep C. difficile in check. Which brings us to another black box warning. Ciprofloxacin and myasthenia gravis. Ciprofloxacin, as well as other fluoroquinolones, can exacerbate muscle weakness in a patient that has myasthenia gravis. Accordingly, patients with a history of myasthenia gravis should not receive these drugs. Drug and food interactions. Cationic compounds. The absorption of ciprofloxacin can be reduced by compounds that contain cations. Among these are the aluminum or magnesium-containing antacids, iron salts, zinc salts, and sucralfate, calcium supplements, and milk or other dairy products, all of which contain calcium ions. These cationic agents should be administered at least 6 hours before ciprofloxacin or 2 hours after. The elevation of other drug levels, then. Ciprofloxacin can increase the plasma levels of several drugs, including theophylline, Coumadin, and tinidazole. Toxicity may result, so for patients who are taking theophylline, drug levels need to be monitored and a dosage needs to be adjusted accordingly. For patients taking Coumadin, your prothrombin time should be monitored and the dosage of Coumadin may need to be reduced. Its preparation, dosage, and administration. So, preparations. Ciprofloxacin again is available both oral and IV administration. For oral therapy, ciprofloxacin is supplied in immediate release tablets, sold as Cipro, as well as a suspension and extended release tablets, sold as Cipro XR. For IV therapy, ciprofloxacin is supplied in a solution sold as Cipro IV. For dosages specific, hit pause and take a look. We're going to be going through a lot of different dosages for a lot of different things. I'm going to skip over those portions because, one, these dosages will change, and two, there's going to be so many different dosages that I'm going to be reading out loud that you're not going to remember it. So you're better off hitting pause, reading them over, making note cards or flashcards for yourself, if necessary. So, dosage and administration for oral. Dosing may be done with or without food. The dosage for complicated UTIs is 250 or 500 milligrams 2 times a day for about 7 to 14 days. For other infections, dosages can range between 500 to 750 milligrams twice daily. Dosages need to be reduced again for patients that have renal impairment. Dosages for anthrax prevention are presented later, something that you will rarely see. IV dosages can range anywhere between 200 to 400 milligrams every 12 hours. And again, the dosage for anthrax will be different. Inhalation, so anthrax. Ciprofloxacin is used to reduce the incidence of anthrax or prevent anthrax progression in people who have inhaled B. anthracis spores. The dosage for adults is 500 milligrams oral every 12 hours for 60 days. The dosage for children is about 15 milligrams per kilo orally every 12 hours for 60 days. For other systemic fluoroquinolones, so we do have other medications, ofloxacin. Ofloxacin's basic pharmacology is very similar to that of ciprofloxacin in mechanism of action, antimicrobial spectrum, therapeutic application, and adverse effects. Again, similar to ciprofloxacin, the drug is administered orally. Its bioavailability is very high at 90% in the absence of food and is greatly reduced, however, with the presence of food. Ofloxacin is widely distributed to tissues and excreted in the urine. Again, similar to ciprofloxacin, ofloxacin can cause a variety of mild adverse effects, including nausea, vomiting, headache, and dizziness. In addition, ofloxacin may intensify sensitivity to sunlight, thereby increasing the risk for severe sunburns. Like other fluoroquinolones, ofloxacin can exacerbate muscle weakness in patients with myasthenia gravis and increase the risk for Clostridium difficile, as well as cause tendinitis and tendon rupture, especially again in the patient population that is 60 years or older or are taking glucocorticoids, or those who have undergone heart, lung, or kidney transplants. Ofloxacin elevates plasma levels of coumadin, but unlike ciprofloxacin, has little effect on levels of theophylline. Absorption of oral ofloxacin is reduced by cationic substances, so that milk products, sucralfate, iron and zinc salts, and magnesium and aluminum containing antacids. Ofloxacin's preparation, dosage, and administration, therefore. Again, ofloxacin is available in oral dosing with or without food. The usual dosage is anywhere between 200 to 400 milligrams every 12 hours. Treatment duration can range from 1 day to 6 weeks. Dosage, again, should be reduced in a patient that has an impaired renal system. Which brings us to moxifloxacin. Its basic pharmacology of moxifloxacin, also known as Avalox, is a broad-spectrum fluoroquinolone indicated for respiratory tract infections, so your community-associated pneumonia, acute sinusitis, acute exacerbations of chronic bronchitis, intra-abdominal infections, and infections of the skin and skin structure. Administration again is either oral or IV. The drug is well absorbed from the GI tract. It undergoes wide distribution and is eliminated by hepatic metabolism as well as renal excretion. Side effects are generally mild and most common being nausea, vomiting, diarrhea, stomach pain, dizziness, and an altered sense of taste. Similar to other fluoroquinolones, moxifloxacin can promote the development of CDI, exacerbate muscle weakness in patients with myasthenia gravis, and cause tendinitis and tendon rupture. The drug also poses the risk for phototoxicity. Moxifloxacin does not increase levels of coumadin or digoxin, but it does, however, prolong the QT interval and therefore may pose its own risk for causing a different type of dysrhythmia. Accordingly, the drug should be used with great caution, if at all, in patients who are taking a pro-dysrhythmic drug or in those who have hypokalemia or a pre-existing QT prolongation. So, its preparation, dosage, and administration. Again, for systemic therapy, moxifloxacin is available in 400 milligram tablets and in solution 400 milligrams in 250 ml for a slow IV infusion. Both oral and IV dosages are the same and should be reduced in patients that have renal impairment. The usual dosage for sinusitis and pneumonia is 400 milligrams once a day for 10 days, and the usual dosage for bronchitis is 400 milligrams once a day for 5 days. Oral dosing may be done with or without food. However, because absorption can be reduced, again by those cationic substances, moxifloxacin should be administered at least 4 hours before these agents or 8 hours thereafter. Which now brings us to levofloxacin, or Levaquin, which is active against Streptococcus pneumoniae, H. influenza, S. aureus, Enterococcus faecalis, Streptococcus pyogenes, and Proteus mirabilis. Approved indications include for UTI, chronic bacterial prostatitis, inhaled anthrax, complicated skin and skin structure infections, and certain respiratory tract infections, such as your acute maxillary sinusitis, acute bacterial exacerbations of chronic bronchitis, and CAP, including CAP caused by penicillin-resistant pneumococci. Possible adverse effects include peripheral neuropathy, rhabdomyolysis, tendinitis, tendon rupture, phototoxicity, and CDI, as well as muscle weakness in patients with myasthenia gravis. To treat systemic infections, levofloxacin may be administered orally or IV. Absorption from the GI tract is reduced by cationic substances, but not by most foods. Levofloxacin is available in tablet and oral solution and a solution for slow IV infusion. The usual dosage is about 500 milligrams once a day for 7 to 14 days. In patients again with renal impairment, the dosage is 500 milligrams every 48 hours. Oral doses may be taken again with or without food. Bringing us to gemifloxacin. Gemifloxacin, also known as Factive, its therapeutic use is an oral fluoroquinolone approved for 2 respiratory tract infections in adults, mild to moderate CAP, and acute bacterial exacerbation of chronic bronchitis. The drug is active against H. influenza, Moraxella catarrhalis, Chlamydia pneumoniae, Mycoplasma pneumonia, Legionella pneumophila, and S. pneumoniae, including strains that are multi-drug resistant. Gemifloxacin causes a high incidence of rash, and compared with other fluoroquinolones used for respiratory tract infections, has no significant advantage and is more expensive. Accordingly, the older agents, such as levofloxacin and moxifloxacin, are actually preferred. Its adverse effects. Gemifloxacin, again, is generally well tolerated. The most common reactions are diarrhea, rash, nausea, headache, abdominal pain, vomiting, dizziness, and an altered sense of taste. In addition, the drug may cause tendinitis, tendon injury, phototoxicity, hypersensitivity reactions, liver damage, and CDI, as well as muscle weakness in patients who have myasthenia gravis. Like some other fluoroquinolones, gemifloxacin can also prolong that QT interval, thereby posing a risk for dysrhythmias. Accordingly, the drug should not be used by a patient who is taking pro-dysrhythmic drugs or those with hypokalemia or pre-existing QT prolongation. The incidence of rash with gemifloxacin is much higher than with other fluoroquinolones. Women younger than 40 years are at greatest risk. Symptoms are severe in about 10% of patients who develop a rash. In the rest, symptoms are mild to moderate. So as a rule, gemifloxacin-induced rash resolves spontaneously, usually in 1 to 2 weeks, although some patients require treatment with a systemic glucocorticoid. If rashes do develop, gemifloxacin should be discontinued. Other drug interactions. As with ciprofloxacin, absorption of gemifloxacin can be reduced by compounds again that contain cations. So among these are the iron salts, zinc salts, sucralfate, aluminum or magnesium containing antacids, and milk or dairy products that contain calcium ions. So to ensure adequate absorption, these cationic agents need to be administered at least 6 hours before uh, at least 6 hours before gemifloxacin or 2 hours thereafter. So, its preparation, dosage, and administration. Again, gemifloxacin is available in 320 milligram tablets for oral dosing, with or without food, excluding again those cationic agents. The dosage for CAP again is 320 milligrams once a day for 7 days, and the dosage for your acute bronchitis exacerbation, and it's 320 milligrams once a day for 5 days. For patients that have severe renal impairment, the dosage needs to be reduced. To prevent high concentrations in the urine, all patients should consume liberal amounts of fluids. Which brings us now to the additional antibacterial drugs. Metronidazole, also known as Flagyl, which is what I'll be calling it. Still very popular today, it is used for protozoal infections and infections caused by obligate anaerobic bacteria. The basic pharmacology of Flagyl is discussed in Chapter 81, as is the drug's use against protozoal infections. Considerations here are limited to the antibacterial application. So, its mechanism of antibacterial action. Flagyl is lethal to anaerobic organisms only. To exert bactericidal effects, Flagyl must first be taken up by cells and then converted into its active form. Only anaerobes can perform this conversion. The active form interacts with DNA to cause strand breakage and loss of helical structure, effects that result in the inhibition of nucleic acid synthesis and ultimately cell death. Because aerobic bacteria are unable to activate Flagyl, they are insensitive to the drug. So its antibacterial spectrum. Again, Flagyl is active against obligate anaerobes only. Sensitive bacterial pathogens, though, include Bacteroides fragilis, C. difficile, Fusobacterium species, Gardnerella vaginalis, Peptococcus species, and Peptostreptococcus species. So, its therapeutic use. Flagyl is active against a variety of anaerobic bacterial infections. They're really hammering this in. Aerobic does not work. Anaerobic works, including the infections of the CNS, abdominal organs, bones and joints, skin and soft tissues, and genitourinary tract. Frequently, these infections also involve aerobic bacteria, and therefore therapy must include a drug active against them. Flagyl is a drug of choice for C. diff, as discussed in Chapter 70. In addition, the drug is employed for prophylaxis and surgical procedures associated with a high risk for infection by anaerobes. Flagyl is also used in combination with tetracycline and bismuth subsalisates to eradicate H. pylori in people that have peptic ulcer disease. Development of resistance to flagyl is rare. So its preparation, dosage, and administration. For the initial treatment of serious bacterial infections, flagyl is administered IV. Under appropriate conditions, the patient may switch to an oral therapy. So its IV formula. Flagyl is available in a solution for IV use. The solution contains about 5 milligrams of flagyl per ml and is ready for IV use. For IV dosage and administration, therapy of anaerobic infections in an adult is initiated with a loading dose of 15 milligrams per kilo. After that, maintenance doses of 7.5 milligrams per kilo are given every 6 to 8 hours, and treatment can last anywhere between 1 to 2 weeks. Flagyl is supplied in capsules, immediate-release tablets, and extended-release tablets. Again, the adult dosage for anaerobic infections is 7.5 milligrams per kilo every 6 hours. For bacterial vaginosis in adults, the dosage is 750 milligrams of the extended-release dose. Once daily for 7 days should be more than enough. The dosage for C. diff is 500 milligrams 3 times a day for 10 to 14 days. Which now brings us to its black box warning on flagyl. Flagyl has been associated with an increased carcinogenic risk in mice and rats, so they don't want you to use it unnecessarily. Daptomycin, also known as cubicin, still popular today, is the first representative of a new class of antibiotics, the cyclic lipopeptidases. The drug is unique mechanism and can rapidly kill virtually all clinically relevant gram-positive bacteria, which includes the methicillin-resistant S. aureus. Daptomycin is devoid of significant drug interactions, and the only notable side effect is possible muscle injury. The drug is given once daily via IV infusion, and there is no need to monitor its plasma level. So how does it actually work? Well, daptomycin has a novel mechanism of action. The drug inserts itself into the bacterial cell membrane and thereby forms channels that permit efflux of intracellular potassium. Loss of intracellular ions has two effects. First, it depolarizes the cell's membrane, and second, it inhibits the synthesis of DNA, RNA, and proteins and thereby causes cell death. Its antibacterial spectrum, therefore. Daptomycin is active against gram-positive bacteria. The drug cannot penetrate the outer membrane of a gram-negative bacteria, and therefore cannot harm them. Daptomycin is rapidly bactericidal to staphylococci, including the methicillin and vancomycin-resistant S. aureus and methicillin-resistant Staphylococcus epidermidis. Enterococci, again including the vancomycin-resistant Enterococcus faecium and E. faecalis. Streptococci, including the penicillin-resistant S. pneumoniae, and most other aerobic and anaerobic gram-positive bacteria. As a rule, daptomycin is more rapidly bactericidal than either vancomycin, linezolid, or quinopristine/dalfopristin. So, its therapeutic use. Daptomycin has two approved indications: bloodstream infections with S. aureus and complicated skin and skin structure infections. caused by susceptible strains of the following gram-positive bacteria: S. aureus, S. pyogenes, Streptococcus agalactiae, Streptococcus dysgalactiae, subspecies Equisimilis, and E. faecalis. The drug is being tested for other possible uses, which may or may not be approved at this time already, but they should include endocarditis and infections caused by VRE, or vancomycin-resistant enterococci. Daptomycin should not be used for CAP. Clinical trials have shown that in CAP patients receiving daptomycin, the rate of death and serious cardiorespiratory events was actually higher than in patients receiving equally effective alternatives. Resistance. Out of more than 1,000 patients who ended up receiving daptomycin in clinical trials, only 2 had infections resistant to the drug. The mechanism of resistance has not been identified, and there are no known mechanisms by which resistance can be transferred from one bacterium to another. Also, there is no cross-resistance between daptomycin and any other class of antibiotics. Its pharmacokinetics, therefore. Daptomycin is administered by an IV infusion, and a significant fraction, up to 92%, becomes bound to plasma proteins. The drug undergoes minimal metabolism. Most of each dose is excreted unchanged in the urine. In patients with normal renal function, the half-life is about 9 hours. However, those with severe renal impairment and in those on hemodialysis or continuous ambulatory peritoneal dialysis, the half-life increases threefold. As a result, the dosage is not reduced, but the plasma drug levels can rise dangerously high. Adverse effects? Well, daptomycin, again, is generally well tolerated. The most common adverse effects are constipation, nausea, diarrhea, injection site reactions, headaches, insomnia, and a rash. Daptomycin may pose a small risk for myopathy. In clinical trials with doses that were larger and more frequent than those used today, patients often experienced muscle pain and weakness in association with increased levels of creatinine phosphokinase, a marker for muscle injury. However, with currently approved doses, elevation of CPK is considered rare. So there is some patient education. Patients need to be warned about the possible muscle injury and told to report any muscle pain or weakness to their provider. In addition, CPK levels should be measured at least weekly. If the level does rise markedly, daptomycin should be discontinued. Daptomycin should also be discontinued in a patient who reports muscle pain or weakness in conjunction with more moderate rise in CPK. Daptomycin can cause eosinophilic pneumonia, which is a rare but serious condition in which eosinophils, or white blood cells, accumulate in the lungs and thereby impair lung function. Symptoms would include ear fever, cough, and shortness of breath. When left untreated, the condition can rapidly progress to respiratory failure and potential death. Other drug interactions. Daptomycin appears devoid of significant drug interactions. It does not induce or inhibit cytochrome P450 and should not affect drugs that are metabolized by the enzyme system. During clinical studies, daptomycin did not affect the kinetics of Coumadin, simvastatin, or aztreonam. Concurrent use of daptomycin plus tobramycin caused a moderate increase in daptomycin levels and a moderate decrease in tobramycin levels. Accordingly, caution is needed when these drugs are combined. Like daptomycin, the HMG-CoA reductase inhibitor can cause myopathy. However, during the clinical trials, no patient receiving simvastatin plus daptomycin developed signs of muscle injury. Nonetheless, given our limited experience still with daptomycin, it may be prudent to suspend HMG-CoA reductase inhibitors while daptomycin is being used. Its preparation, dosage, and administration, therefore. Daptomycin or cubicin is available as a powder in 500 mg single-use vials. For patients with a normal renal function, the dosage is 4 to 6 mg per kilo once every 24 hours. For patients again with severe renal impairment or for those on hemodialysis or continuous peritoneal dialysis, the dosage is 4 to 6 milligrams per kilo, once every 48 to 72 hours. Which brings us to rivampin, or Rivadin, which is still used today, which is a broad-spectrum antibacterial agent employed primarily for tuberculosis. However, the drug is also used against several non-tuberculosis infections. Rivampin is useful in treating asymptomatic carriers of Neisseria meningitidis, but it does not given to treat active meningococcal infection. Unlabeled use includes the treatment of leprosy, gram-negative bacteremia in infancy, and infections caused by S. epidermidis and S. aureus. Rivampin has also been employed for the prophylaxis of meningitis due to H. influenza. Because resistance can develop rapidly, established bacterial infections should not be treated with rivampin alone. The basic pharmacology of rivampin and its use in tuberculosis is discussed in Chapter 75. Rivaxamin, or Xifaxan, is an oral non-absorbable analog of rivampin, again used to kill bacteria in the gut. Like rivampin, rifaximin inhibits bacterial DNA-dependent RNA polymerase and thereby inhibits RNA synthesis, resulting in inhibition of protein synthesis and subsequent bacterial death. Rivaxamin has 3 approved uses. The drug was approved initially for traveler's diarrhea caused by E. coli in patients at least 12 years old. Rivaxamin is not effective against severe diarrhea associated with fever or bloody stools and should not be used if these are present. Rivaxamin is also indicated for the prevention of hepatic encephalopathy in patients with chronic liver disease. Rivaxamin helps prevent encephalopathy by killing the intestinal bacteria that produce ammonia. More recently, rivaxamin was approved for the treatment of irritable bowel syndrome with diarrhea and is marketed under the name Xifaxan. Off-label use of rivaxamin includes recurrent C. diff infections. Rivaxamin is administered by mouth, and very little, less than 0.4%, is actually absorbed. So as a result, the drug achieves high concentrations in the intestinal tract and then is excreted unchanged in the stool. It is well tolerated, and gastrointestinal effects such as nausea, gas, defecation urgency occur in some patients. Because so little drug is actually absorbed, systemic effects are actually minimum. However, studies in rats and rabbits have indicated that rivaxamin is teratogenic and therefore should not be used by pregnant or breastfeeding women. There have been post-marketing reports of hypersensitivity reactions, which include a rash, allergic dermatitis, urticaria, pruritus, and angioneurotic edema. But rivaxamin has not been clearly identified as the cause. Rivaxamin is available in both 200 and 550 milligram tablets for oral dosing, with or without food. For traveler's diarrhea, 200 milligrams 3 times a day for 3 days is great. To prevent hepatic encephalopathy, the dose is 550 milligrams twice a day, as long as needed. In the treatment of IBS, the dose is 550 milligrams 3 times a day for up to 2 weeks. This course may be repeated twice for recurrent disease. Which brings us to fidaxomicin. Fidaxomicin, or Difficid, is a narrow-spectrum bactericidal macrocyclic antibiotic indicated only for diarrhea associated with C. diff. In one trial, fidaxomicin was compared with vancomycin, the standard treatment for C. diff. The cure rate with fidaxomicin was higher than with vancomycin, and the recurrence rate was lower. Similar to rifaximin, fidaxomicin inhibits the DNA-dependent RNA polymerase and thereby inhibits RNA synthesis, causing inhibition of protein synthesis and subsequent bacterial death. Fidaxomicin is administered by mouth, and systemic absorption is low. As a result, the drug achieves high concentrations in the intestines, where it acts to kill C. diff. The most common adverse effects were nausea, vomiting, abdominal pain. some GI hemorrhages, anemia, and neutropenia. Fidaxomicin is supplied in a 200 mg tablet for dosing with or without food. For C. diff, 200 mg twice daily for 10 days is enough. A course of treatment of fidaxomicin is more expensive than with vancomycin. And just to compare the cost back in 2015, it was $5,900 versus $2,050. Bacitracin. Bacitracin is a polypeptide antibiotic that produced by a strain of Bacillus subtilis. Administration is topical. Because systemic administration can cause serious toxicity, and because superior systemic agents are available, bacitracin is no longer available for systemic infections. Its mechanism of action and antimicrobial spectrum, therefore. Bacitracin inhibits synthesis of the bacterial cell wall, thereby promoting cell lysis and death. The drug is active against most gram-positive bacteria, which includes our Staphylococci, Streptococci, and C. diff. Neisseria species and H. influenza are also susceptible, but most other gram-negative bacteria are resistant. Acquisition of resistance by sensitive organisms is uncommon. Its therapeutic use, therefore. Bacitracin is used for topical treatment of bacterial infections. The drug is very active against Staphylococcus and group A Streptococcus, the pathogens that cause most acute infections of the skin. Because of this activity, bacitracin has been marketed in a variety of topical preparations for treatment of skin infections. Many of these preparations contain additional antibiotics, usually polymyxin B, neomycin, or a combination of both. Which brings us to polymyxin B. Polymyxin B is a bacterial drug employed primarily for local effects. Because of serious systemic toxicity, parenteral administration is rare. Its antibacterial spectrum and mechanism of action, therefore. Polymyxin B is bactericidal to a broad spectrum of aerobic gram-negative bacilli. Gram-positive bacteria and most anaerobes are resistant. Bactericidal effects result from binding of polymyxin B to the bacterial cell membrane, an action that disrupts membrane structure and thereby increases membrane permeability. The increased permeability leads to inhibition of cellular respiration and cell death. The resistance displayed by gram-positive bacteria has been attributed to the thick gram-positive cell wall, a structure that may block access to polymyxin B to the cell membrane. Its therapeutic use, therefore. Polymyxin B is used primarily for topical treatment of the eyes, ears, and skin. Preparations designed for application to the skin frequently contain other antibiotics, such as bacitracin and neomycin. In addition to its uses, polymyxin B, together with neomycin, has been employed as a bladder irrigant to prevent infection in patients with indwelling catheters. Parenteral use is extremely limited. Polymyxin B is not a drug of choice for any systemic infection. The primary indication for parenteral polymyxin B is serious infection caused by P. aeruginosa. Polymyxin B may be given when preferred drugs have been ineffective or intolerable, which leads us to its black box warning, neurotoxicity, nephrotoxicity with polymyxin B. The major adverse effect associated with parenteral therapy are neurotoxicity and nephrotoxicity. Both occur frequently and limited systemic use of the drug. And that concludes our chapter here for today. As always, I thank you for listening, and I'll see you at the next chapter. Till then, take care and goodbye.